Hi, so hello. Thank you for coming to listen to me talking today. My name is Andrew Whitehead. I'm an intensive care and anaesthetic registrar and simulation fellow, previously based in Reading. And this is some exciting work that I've been involved with last year about increasing the confidence of recovery staff and managing emergency scenarios. So, team training has been proposed as a way of improving information sharing in post-anaesthesia care units. And I'm not going to dwell on the evidence for long because this is a simulation conference. I'm probably preaching to the converted, but there's lots of studies that associate an improvement in various metrics: communication, clinical skills, confidence, following an education event based around simulation. And we wanted to use that, maybe take it a little bit further, slightly change the way we were delivering it so it fitted in with the way our practice worked day to day. And so these are our aims. We'd recently recruited some new staff members to our recovery team, and we wanted to integrate them into the existing team. And we wanted to improve the confidence of all of our team members in managing some emergency scenarios in the time that they're waiting for extra help to arrive. And as you can imagine, while we're devising this project, there were some organisational barriers that we came across. So despite recruiting more staff, we were still short-staffed, and as a result, the Trust had put an embargo on any of the recovery team taking study leave, which sort of precluded a separate study day. Our simulation centre, although it's on site, is quite remote to our theatre complex, and trying to move participants from theatre to the sim centre, leaving gaps between cases, just wasn't practical. And if we were to try and put that pressure on them, rushing them there, rushing them back, probably not going to be that accommodating of Maslow's hierarchy of its needs. So we're thinking of what our solution was going to be. We were going to bring simulation to the staff, run it in situ, and we're going to try and really identify and make the most of the low activity periods. And this is on the background of having a positive response to previous in-situ simulation work and T-trolley simulation work that I'd been involved in previously. So, quick overview of our project. First, we wanted to run a feasibility pilot before we even thought about what scenarios we were going to run. And I'll talk a little bit more about that part of our project a little bit later on. We wanted to get a baseline level of what our recovery staff rated their confidence like managing certain scenarios. And we did this using a paper-based questionnaire that we asked the team leaders at the beginning of the day to hand out to their staff, getting them to rate on a scale of 1 to 10 how confident they were on a list of scenarios. And then we planned to run 8 weekly sessions in situ in the theatre recovery area. And before and after these sessions, we were collecting feedback, not only on how useful they felt the sessions were, but also to rate their confidence again, immediately before and then immediately afterwards. And then, at least 4 to 6 weeks after they were involved in their most recent simulation, we redistributed our survey, asking staff to rate their confidence again at a remote point, having taken part in the simulation, or if that was a recovery member of staff filling out the survey who hadn't been involved in the simulation, we asked them to do that as well. So we ran our feasibility pilot really to determine exactly what was going to be possible, how we were going to do it, the practicalities, getting equipment to recovery, where we were going to set it up so it didn't interrupt what else was going on, and how we could design our scenarios to make them as realistic as possible, optimize the learning environment while enabling the rest of theatre recovery to function as normal. So we chose 2 scenarios, an anaphylaxis one and an opioid toxicity one, as our trial scenarios. And we really found that running those enabled us to get good buy-in, not only from those that were already sort of invested in the study group, but other users of recovery, the matron who occasionally would walk through, or the other theatre team, the other anaesthetists who would come and deliver their patients, just so they got an idea of what we were planning to do. And it also allowed us to get input from the recovery staff themselves, so they could share what needs they had. And doing this, we learnt a few things. We learnt that mornings are the best time to do this because the first cases haven't finished yet, particularly Monday mornings, because there were no overnight cases left in recovery. And we found we needed to control the group size. At the beginning of the day, lots of recovery staff are free. As the morning progresses, they start getting more occupied with clinical work. But that if we had 2 or 3 participants in the group, that seemed to be the optimal level of interaction, both in the scenario and in their debrief afterwards. And although it wasn't one of our aims, we also identified our first latent threat, and that was we didn't have any naloxone labels in stock, nor were they on the stock list for recovery. So in terms of selecting our scenarios, we made a shortlist. We did this by trawling through incident reports, looking for themes, and then discussed these in a focus group that consisted of representatives from anaesthetics, from recovery, and also from the practice educators. And we came up with this list of 12 scenarios, which far too many to start to comprehend to run in our small project. So we gave this list to our anaesthetic consultants, and we asked them to rank them on a scale of 1 to 12 on the basis of which ones they thought were going to be most important for recovery staff to be able to identify and manage in that short window before help arrives. And then we gave the same list to our recovery staff, getting them to do the same thing and also tell us how confident they were managing those things. And then we used that information to come up with an aggregate score that gave us 5 scenarios that we were going to focus on. And those 5 were airway compromise following cervical spine surgery, bradycardia, concealed bleeding, laryngospasm, and residual paralysis. So regarding the setup of the sessions themselves, a session was a Monday morning, and in that Monday morning we'd run 2 or 3 scenarios. Sometimes it would be the same scenario repeated, other times it would be another one to try and make sure that the staff members that were available weren't repeating scenarios that they'd already been involved with. And the session was very short, so the scenario would run just for 10 minutes, the debrief just for 10 minutes, and although we are aware of the recommendation to have a 1-to-2 ratio of scenario to debrief, we were really acutely aware that we need to fit in with day-to-day working, and compromises were going to need to be made somewhere, and this is where we decided to make one of them. And our participants in our groups, we managed to get between 2 and 4 for each session. So moving on to our results, of our 8 sessions, 6 of them ran. We fortunately needed to cancel 2 because of clinical demand, and that was because recovery was being used to accommodate ward patients. And this is January and February, this is winter in the NHS, so cancelling 2 sessions we thought was actually quite good. We were expecting we probably need to cancel more. And we engaged 34 unique members of the recovery staff, delivered 61 simulated patient encounters, and we've got full data for 53 of those. So our recovery staff really liked these sessions. They found them really useful, rating about 9.5 out of 10 for usefulness. Almost everybody said they would definitely want to take part in more sim like this, and the rest of the people said that they probably would like to take part in simulation like this. And we were quite pleased over the whole program. We didn't receive any adverse comments about our activity interfering with patient care or concern to that effect. And I want to share some of our free text comments we got back. I particularly like this one. I really liked the chat at the end. I presume they mean the debrief. They felt our simulation instilled them with confidence to share their thoughts, to speak up, and propose suggestions, all of which are values we want to be encouraging in our staff. And other members mentioned being able to think about using their initiative, what little things that they can do themselves while they're waiting for help to arrive. So it wasn't in our aims, but in addition to our latent threat that we spotted in our pilot study, we identified 4 more. Sagamodex is a specific reversal drug for certain neuromuscular blocking medicines, and that wasn't available in recovery. And actually, one of my colleagues had done a quality improvement project for anaesthetic trainees, making little badge-sized reference cards saying where various bits of emergency equipment were, depending on which theatre complex you're in. So that was quite easy to rectify. We could just make that card available to our recovery staff. As a result of our CQC inspection, all our medicines got locked away, which really highlighted the need to know who's got the keys, but also for the person with the keys not to wander off with the keys. And we also found that our emergency drug box, which has got mostly medicines for emergency induction, didn't have adrenaline in. Our adrenaline was stored in a separate part of recovery in our anaphylaxis kits. And also that the ODP bleep that's on the team called for an anaesthetic emergency was not carried out of hours, another thing that we were able to rectify. So this is a very simple chart with our confidence scores immediately before and immediately after taking part in our simulation. And as you can see, there's a significant increase of about 3 points. But we wanted to see whether this confidence was retained further down the line. And again, on this chart, you've got confidence up the y-axis, time along the x-axis, and 3 lines. The green and the blue line relate to our study scenarios, the green line being confidence of participants who took part in the scenarios, and the blue line being confidence of patients who, confidence of the participants who weren't doing those particular scenarios. And then the red line, all of the respondents to our survey for the scenarios that were on our shortlist, but that we didn't simulate. And as you can see, there's been a significant improvement which persists for at least 4 to 6 weeks in the group of participants who took part in our simulation. And there's not a change at all for the other groups. So in conclusion, in-situ simulation in recovery is useful, it is feasible, our participants enjoyed it, it instilled values that we want to be encouraging in our teams, and it didn't make any impact on the routine working of the department. It revealed some latent threats, which we hope made our recovery safer, and that the confidence that it instills in our team is retained. So thank you very much for listening, and if anyone has any questions, I shall do my best to answer them.